Hi everybody, this is the flipped classroom for the fourth quarter. We're going to be talking about traumatic injuries to the central nervous system and focusing in on the brain. And then we're also going to have a little discussion about the ramp triage model. As far as talking about head injuries, obviously we know that numerous source materials, numerous books classify different types of traumatic brain injuries, and we'll discuss them briefly and review them. And then we're going to talk predominantly about primary and secondary injury, and specifically we're going to focus in on subdural and epidural hemorrhages. And then some of the things that we can do as far as treatments in order to prevent that secondary injury. As I said, many sources, many texts classify traumatic brain injury into multiple different categories, from skull fractures through contusions, which is going to envelop all the hematomas, concussions, lacerations where we're actually damaging brain tissue either from a penetrating object or depressed skull fragments, and a diffuse axonal injury, that shearing force that we get in shaken baby syndrome, and as well as some rapid deceleration, coup, counter coup type injuries within the brain. Skull fracture, pretty self-explanatory. We know that the skull itself has been fractured. Now, the big thing is that regardless of if there's a non-displaced skull fracture or a displaced skull fracture, we still have significant impact, and those forces are going to transmit through to other parts of the body. In this case, it would be the brain. So we know with a skull fracture, we can have a skull fracture that has overlapping and interlacing other issues. Contusion as well as elements of concussion can all be present. When we talk about contusions, this is where we're actually bruising the brain itself, which is going to cause a cascade of other issues, swelling and inflammation. And then, of course, because the brain is encased within that skull, if the skull is intact, with that inflammation and swelling, we're going to have increases in pressure within the skull itself. This is where you're going to have your epidural, your subdural, your subarachnoid bleeds, and your intracerebral bleeds. With concussions, this is something that has changed significantly from my youth and many of us in our youth. Back in the day, it wasn't a concussion unless you had a blow to the head that caused unconsciousness. That's really been revamped quite a bit, and they're really looking at concussion as more of any blow to the head that causes cognitive impairment is going to be classified as a concussion. There does not have to be a loss of consciousness. If there's a loss of consciousness, then at the absolute bare minimum, the patient's concussed, as well as could have other more serious injuries. And not that a single concussion isn't a serious injury. The new research shows that obviously with repetitive concussions causes changes in our brain and our brain function. Something that isn't a traumatic brain injury, but I felt would be appropriate to throw in at this point, is amnesia. And the fact that amnesia is one of those common presenting symptoms and signs of concussion. The two that are typically discussed and talked about in almost all the pre-hospital literature are anterograde amnesia, where we can't form any new memories, so it severely impacts our short-term memory. This is that patient that, as you're transporting into the hospital, gives you the repetitive questioning over and over. It's like, oh my God, what happened? You were in a car accident. I was? Yes, you were. Oh my God, was anybody else hurt? No. And then it's literally like hitting rewind on the recorder. Oh my God, what happened? You were in a car accident. And it's that same repetitive questioning over and over, because their ability to form that short-term memory of that discussion is gone. The other that we'll sometimes see in concussion is retrograde amnesia, where we lose older memories from our youth or from years ago. So this isn't short-term memory issues. This is where we're having difficulty accessing our long-term memory. Amnesia has a couple of other classifications that don't get discussed pre-hospitally very often. One is post-traumatic amnesia, and this is after a significant head injury where we get elements of both anterograde and retrograde amnesia. The other is transient global amnesia, and this is a temporary syndrome where the patient has loss in both, but it's sudden and it's very brief. In 24 hours it has resolved and they have normal memory again. Now, as far as that anterograde amnesia, you'll kind of see three presentations pre-hospitally with patients who get a severe blow to the head. They'll have no recollection of events that day up to the accident or the incident. They'll have no recollection of the incident itself, or they'll have that inability to form that short-term memory of things that are happening after the incident. But those are three distinct periods that can be lost. But more often than not, my experience was transporting those patients into the hospital. It was the repetitive questions and it was the inability of their brain to latch onto those short-term memory events. When we start talking about lacerations to the brain, it's exactly it. It's direct damage to the brain tissue itself. That could be a foreign object that has impaled the brain or penetrated the skull. That can be from a skull fracture that has depressed skull fragments with pieces of skull embedded within the brain itself. But there's some actual demonstrable injury and tear to the tissue itself. With that diffuse axonal injury, this is that rapid moving back and forth, coup counter coup, shaken baby, where we get these shearing forces put on the neurons themselves. And on imaging often appears as this diffuse, cloudy injury pattern in multiple areas within the brain. Regardless of what type of TBI classification their injury falls under, we've got the primary injury. That's the moment of the accident, the moment of the traumatic event. There's nothing that we can do to fix that immediate injury. That damage is done. Where it's imperative on EMS providers' part and at the end result, the hospital's part, is all about preventing that secondary injury and allowing more brain tissue, more brain damage to occur. So with secondary, this is where we can be impactful. This is going to be correcting a patient that's not breathing adequately, making sure they're oxygenated, making sure that their brain has adequate perfusion. That's how we're going to minimize secondary injury. So secondary trauma, secondary injury is going to be predominantly because of hypoxia, hypoperfusion, causing ischemia of the brain tissue. Along with that, and if we kind of look at these symptoms here within secondary trauma, this is kind of like a continuum of as the injury progresses. With that injury to the brain, we're obviously going to typically get swelling and cerebral edema. With that, because the brain is encased within that rigid structure of the skull, we're going to, especially if we have swelling of the brain tissue and or blood loss within the brain or the brain area around it, we're going to get increased intracranial pressure. And depending on their breathing, if they're hypoventilating, we're also going to have a buildup of carbon dioxide. Some other secondary injuries that aren't directly resultant from our care are going to be, there's the possibilities for infection, abscess, meningitis. They can have changes in their biochemical state. Their neurotransmitters can be off. And of course, if brain function is impaired at the level of the neurotransmitters, it's going to cause some other issues as well. The last one that kind of goes over a couple of different, in my mind, realms is the development of epilepsy and or seizure. With a lot of these blows to the head, specifically if there's demonstrable injury to the brain, seizures are evident. The brain has gone through a lot of trauma. The patient will often have seizures. And as a result of that damage to the brain, they may develop long-standing, lifelong seizure disorders afterwards as well because of the traumatic brain injury. So when we start kind of keying in on subdural versus epidural, in the grand scheme of things, for your care on the street, does it make a difference? No. But it does make a difference as far as how the patients are going to present, the condition of the patients, and their mortality in the end. If we're talking about subdural, which we're kind of really going to focus a little bit more on the subdural versus the epidural. But with a subdural bleed, this is a bleed that has occurred underneath the dura mater, and the issue with it occurring underneath the dura is that now that blood has the ability to get out and across suture lines and get global throughout the brain. And by that very virtue, the more blood that gets out and around the brain, the more pressure it is going to exude on the brain, and the more swelling and inflammation it can trigger as a result. And this aspect makes the subdural a more deadly injury. So there are always the people who want numbers, and there's kind of conflicting numbers, and multiple sources put the mortality rate of subdural hematoma anywhere between 36 and 79%. That's kind of a broad range, but favorable outcome rates with adequate treatment is between 14 and 40% of those injuries. And if you look at the bottom of this slide, predominantly it's the elderly patient, and it's got almost a very specific presentation. It's that person who gets up too quick or gets out of bed, they do the teeter-totter, they fall over, then they're striking the temporal side of the head, and they dismiss it as, oh, I bumped my head. And it's far worse than that. So there's a couple of illustrations that we're going to show here. Both of them show kind of the difference side by side. On this slide, the left side is the epidural, on the right side is the subdural. With the epidural, typically there is damage to the skull, and that blood is going to be a torn artery, and it's going to be outside the dura. Now the good thing about that is it allows the blood has less area where it can spread. It can still build quickly, and it can still give us signs and symptoms quickly because it's a torn artery. But it doesn't have the same slow approach. By slow approach, on the right side with the subdural, this bleeding is occurring underneath the dura mater. As I said, because it's underneath the dura, it has access to go all over the brain itself. Whereas here, if you look at that epidural, it has caused blood to pocket between the skull and the dura that it has peeled off of the skull. But that dura is in essence connected to the skull, and so for it to continue to spread, it's going to be really pretty confined. With the subdural, that's not the case. It's underneath that barrier. It's got access to the brain itself. It can really fill that area up and provide a lot of pressure. And this is I like this animation only because if you look at what we're talking about, the subdural crosses across those suture lines and can get global, whereas that epidural doesn't cross the suture line, limiting its ability to build up that same pressure. Now, subdurals are the most common, and again, this is typically an elderly patient who gets up, falls down, strikes the side of their head, and they dismiss it. And then depending on how big the blood vessel is, the vein that they tear, and how big the tear is how quickly their signs and symptoms are going to come on. And these are going to be those bridging cranial veins, and they just, again, it's typically that older patient because as our brain gets a little bit more atrophied and we get older, it has a little more space to slam around inside our head, and that side impact on the temporal area is just ripe for rupturing those cranial veins. If we look at an epidural, on the other hand, this is far more common is in the younger population. It's trauma with skull fracture almost always involved in a tearing of those underlying blood vessels. So regardless of whether we get the subdural or the epidural, that initial injury, that the primary injury we can't do anything about, but it's about preventing that secondary injury. And the treatment and best results of TBIs has been pretty well known for about 20 years, actually a little over 20 years. And it's maintaining oxygenation, maintaining blood pressure, and maintaining blood sugar. The brain needs oxygen and blood. It needs oxygen in order to process. It needs the blood in order to bring nutrients and take away waste products, be it carbon dioxide or other issues. And when we impair one or all three of these, we greatly increase the insult to the brain. One of the big issues is that with that hematoma occurring within the skull, and because it's such a fixed structure, we can get intracranial hemorrhage without a doubt, but the intracranial hemorrhage leads then subsequently to increased intracranial pressure. And as the symptoms build and as that hemorrhage is creating more and more pressure, the patient presents with initially headaches, maybe some dizziness, some nausea, vomiting, could progress to projectile vomiting. They can have seizures. They can complain of all of those neurologic symptoms that you would typically see with a lesser brain injury like a concussion. Vomiting is very common in concussions. But as we continue to have impaired perfusion of the brain, increasing intracranial pressure, depending on where in the skull the bleed is, we can get all those neurologic changes that we would typically think of in a stroke. We can have hemiparesis, we can have slurred speech, we can have visual changes, all of the same neurologic presentation. When we specifically are talking about increased ICP, it's all about Cushing's triad, and something that we've had driven into us in EMS forever. When I was looking for an animation, this self-drawn on a tablet that somebody had posted just kind of summed it all up really well, and the skull with the crossed eyes just was something that spoke to me. But it's all about, as the blood pressure increases, specifically the systolic blood pressure increases, you'll see both diastolic and systolic increase, but the systolic is really the one that's going to change quicker and more dramatically. As that pressure is building in the skull, the body's increasing pressure to overcome that resistance to keep perfusion going. But as we build pressure and we start pushing that brain through the foramen magnum and putting pressure on the brain stem, we're going to get changes in cardiac rate, we're going to get changes in respiratory rate, and we're going to get changes in respiratory pattern. And it's this continual balancing act of we got to crank the pressure up to overcome the pressure that's in the skull, but of course the more blood we push up there, the more blood that spills out. So it's this virtual chasing its tail, trying to keep the brain perfused. If we start looking at the guideline for head trauma, we do start talking about making differentials, and that's kind of where we wanted to review all of the traumatic brain issues and try and make a determination about what we're doing. Now, one of the big key things, you'll notice the red box on the left, is we really have to avoid hyperventilation. And for those newer medics that are wondering why I'm emphasizing this is for the older providers. And it's one of those things that we really didn't understand very well, and we hyperventilated these patients, and we hyperventilated them way too much. And of course, when we hyperventilate, we over-oxygenate, and we cause vasoconstriction. And with vasoconstriction, now we're impairing the brain's perfusion. So if we are seeing signs of herniation, intracranial pressure is going up, we're seeing the classic Cushing's triad, we can do what is targeted ventilation. I would think is a better term than mild hyperventilation. And by targeted ventilation, we're going to keep their end titles in that lower edge of normal, 35 to 40. We don't want to get below 35 because then we're going to be creating too much vasoconstriction. So it's targeted ventilation so that we maintain that slightly lower end of normal for end tidal carbon dioxide. And then obviously some of the big key things here is that if we've got a patient that's got a severely depressed GCS, we may very well have to cross over and bridge into other protocol guidelines, specifically the RSA, RSI guideline, because it's all about supportive care, and supportive care and minimizing that secondary injury is going to be in the patient's best interests. And then obviously notifying MRCC that you've got a traumatic brain injury, you have a trauma team activation, and getting them transported as rapidly as possible. If you have any questions about head injury, or specifically epidural, subdurals, please hit them my way. Otherwise, if you can, hang on to them until we come out for the in-person delivery of the flipped classroom model. And in addition to the subdurals, we're going to talk a little bit about triage. And specifically, we're going to be talking about ramp triage. And ramp triage is the new preferred method that is listed in the EMS guidelines. And it came about just over 2 years ago, but it was a pretty subtle change. It kind of like was presented into the guidelines. So with ramp triage, people are like, why are we making this change to ramp? We had START, then we went to SALT. Well, there's pluses and minuses to everything. And in reality, the medical directors looked at ramp triage as being an even easier guideline / triage tool for providers to use under high stress. And you'll see why as we get into it. So if we think about triage previously, I know that when I started in EMS, it was all memorized patterns, and if the patient had one long bone fracture that was a distal long bone fracture, then they could be a green. But if it was two yellow, or if it was two long bone fractures that were distal, it could be a yellow. But if it was a proximal long bone, then it's a red. And that's just way too much. And if you look at today, if you were to pull up the CDC's field triage recommendations, you'll see that they have numerous different patterns, injury patterns, presentations to prioritize the patient. Not that obviously it's very specific and it does appropriately triage the patient. For field use under high stress, it's just imminent failure. There's too many things for a provider to try and remember and to think under high stress, making it tougher for them to do their job, and they're going to have more likely side effects post-traumatic stress-wise because they're going to get down on themselves because they couldn't remember the patterns. So personally, I like to study processes, and processes, especially under high stress, it has to be very simple. The more convoluted, the more apt for failure it is. So realizing that the injury patterns were problematic, on the West Coast where START triage initiated, that came into being. And START triage, as you can read, is simple triage, rapid treatment. It was a method for rapidly sorting patients. There were a couple things you had to memorize, but in all, it was fairly easy. And if for START triage you could remember RPM, respirations, perfusion, and mentation, you could do START triage. And the whole thing about START was that it was easier to use. Now we'll talk about, there are some shortcomings about START. We'll talk about that as we break it down a little bit. But START didn't address pediatrics. So since it didn't address pediatric patient populations, Jumpstart came into being. Jumpstart is just a tweaking and a slight change of the START triage guideline. Well, a few years ago, SALT triage came into being, and this was a slightly different model. It was sort, assess, life-saving interventions, and treatment/transport. And it also brought into being another patient category other than our typical 4 patient categories. SALT, to me, because I never used it and I never practiced with it, it doesn't seem as second nature to me. START works very well. I've used START and found it to work well for me, but I did find it to be problematic, and I know that there are some big problems. Some of the big things about START triage is that the initial phase of START is you would get on scene, access your vehicle's PA, and say, hey, everybody who can walk, please come to this ambulance, please come to this fire engine, what have you. And then that would get you, in theory, this mass of walking wounded that would come over. Now, the only problems with that is now I've got a group of people that have to be babysat, but you can have one person kind of do that. But they need to have a secondary triage. They might be having a huge stress hormone release and not realize the nature of their injury and be able to compensate for it and walk over. So here the example is there is a potential gunshot wound that they're not really symptomatic from as of yet. But where I see START triage being potentially even a bigger problem is that it can get you this tidal wave of reds right away. So the whole concept of START, just to do a real quick review, was we're looking at respirations, perfusion, and mentation. Respirations, if they're over 30 a minute, they're red. Perfusion, do they have peripheral circulation? The initial version of START was capillary refill, which this was designed in California. Cap refill works great because it's a very temperate region year-round. Here in the Midwest, where we have winter hell, people get cold. Capillary refill is not reliable. So START triage was kind of morphed a little bit as it spread across the country into be cap refill less than 2 seconds or peripheral pulse. So we got respirations over 30, they're red. If they've got no peripheral circulation, no palpable radial pulse, or cap refill over 2 seconds, they're red. The last one's mentation. If the patient could follow simple commands, they were not a red. But if they can't follow simple commands, they're a red. So the last catch-all was if they passed the test, they weren't breathing over 30, they had peripheral circulation, they got good mentation, but they couldn't walk to you, the assumption was then that they were a yellow. But as you can see, this is a stressful event, not just for rescuers, but for the patient. And if the patient is freaked out, they could be hyperventilating over 30. If they're freaked out, their pulse rate could get fast enough that it could be impaired as far as our ability to feel a radial pulse, our ability to have good cap refill. And more specifically, very likely, their brain could be overloaded to the point they can't follow simple commands. So that first flush could get you an awful lot of reds that as the situation stabilizes, as they get removed from the scene of initial triage to the treatment sector, they get a degree of separation, they can de-escalate a little. They might fall out of the red category. As they get to transport and they get loaded in a rig and get even more removal from the scene and the source of stress, they could de-escalate more and get reprioritized. So this is the point where I, again, kind of organically think that any one of these tools gives us the ability to have some flex. And not only some flex, but the initial triage is just that. It's the initial triage. They get eyes on them in treatment where there might be 6 reds, but then of course within the reds, one's going to be much more acute and need care much more expeditiously than the others. So they will get reprioritized, or they might just get moved out of the red category to the yellow or to the green. So once they get to transport, they're going to get eyes on them again. Once they get to the hospital, they're going to get eyes on them again. So that initial triage isn't the only triage. They're going to be looked at multiple times. Now, as I said, out of START came Jump Start. START didn't address the pediatric patients, and we know that pediatric patients have some other issues. So here, the big changes were in the immediate life-saving treatment portion of START into Jumpstart, and also in the respiratory component. So one thing that START has was the easy life-saving treatments that we could do on scene. One is, if the patient's not breathing, we open their airway. If they spontaneously breathe, they get to continue. If we open the airway on the adult patient, they don't spontaneously breathe, they are tagged as a black or deceased patient. But with the pediatric population and respiratory compromise being a huge component of higher mortality rates, they made a change with this immediate life-saving treatment. You would open the child's airway, and if the patient didn't spontaneously breathe, we check for a pulse. If the patient has a pulse, we're going to give them 5 rescue breaths. Now, at the end of the 5th rescue breath, by the tool's design, if the patient doesn't spontaneously breathe, we would tag them as a expectant or deceased black, and we would move on. Now, I can see this as being problematic for a lot of rescuers, and to walk away from a child they know has a pulse. So this is where I say there's some flex in all these tools. You have to look at what your available resources are. If I've got a 6-car accident, and there's 1 to 2 people per car, so we've got 10 to 12 patients. Relatively small scale MCI. If 5 patients are reds, and 1 is this child, that our 6th patient, and the other 6 are walking wounded, they're green, I don't have the resources to throw at and to dedicate to this child. Now, if I change that up, and even if it is 12 patients, but I've got 11 walking wounded, and I've got this 1 child that has suffered injury and is far more gravely injured than the others, even with staggered resources getting to the scene, I've got somebody babysitting the greens, I may put the resources into resuscitating this child. As long as they have a good, strong pulse, if I can help them breathe, they may have a chance at surviving the event. So there is some flexibility. It's a guideline. It's a tool to make the decisionary process easier. On the same note, one of the other big differences about Jumpstart is respiratory rate. So again, knowing that pediatric patients have very different respiratory and metabolic needs from an adult, Jumpstart says if the respirations are less than 15 or over 45, that's considered a red patient. So now you can see where we're starting to get some layers of possible complication in here. Now you got to remember 3 numbers, 15, 30, and 45. For an adult, are they over 30? For a child, are they under 15 or are they over 45? And I just see this as now we're starting to get into some potential fail areas. Although, at least in my mind, the way my brain works, 15, 30, and 45 are all multiples. It's easy for me to stash that into my brain pan. So SALT triage came about because it is one triage model that does address some pediatric concerns. It also addresses other concerns, and it is one of the few that talks about available resources. To me, however, when I look at it, it doesn't click in my brain the way that START does, but I also had an awful lot of exposure, to be truthfully honest, to the START triage model. Very little exposure on the SALT triage model. But right after the SALT triage model was put into guidelines, the medical director stumbled across the RAMP triage model. And I think that you'll agree and see that RAMP is a much more user-friendly for the field provider. RAMP stands for Rapid Assessment of Mentation and Pulse. And with this, it's a very simple triage tool for the provider to use. There's very little to remember. There's no numbers to remember. It's a very intuitive process. And by intuitive, this is the flow chart. I like the fact of, as in this model, if I'm walking up and I see a patient that has obvious signs of death or catastrophic injuries that are incompatible with life, I can bypass them and go to the next patient. Now, before we can truly put a patient into the flow chart, you see that gray box that says immediate life-saving interventions. So in this model, we are going to control massive hemorrhage as we did with START. We're going to also open up a patient's airway, and if they spontaneously breathe, they get to continue. We'll also do needle chest decompression if the patient has evidence of a tension pneumothorax. These are considered life-saving interventions, and they're quick and they can be done quickly. Now, the nice thing about this, at least in studies where they did START triage and then they had people go through and do ramp triage, roughly to go through the whole START triage model averaged out to be about 55 seconds per patient, whereas to go through the entire ramp model took between 25 and 30 seconds a patient, so basically half the time. So, I mean, you can do the math very simply in your head. If you're doing a triage of 15 patients in the field, it's going to take nearly 15 minutes on average to get them all triaged. With the ramp triage model, in about 7 to 7.5 minutes, you're going to have them all triaged. So far quicker. And now you'll see how easy it is. I go to the patient, can they follow my commands, yes or no? If it's yes, I go down the left branch. If they can follow simple commands, do they have a radial pulse? Again, if it's yes, boom, we're to green, delayed. If, however, they can follow simple commands, but they don't have a radial pulse present, obviously they're decompensating, obviously we have signs of shock, they get pigeonholed into the red urgent category. If we back up to following simple commands and they can't, automatically we are to the pulse again. So again, there's only two things to check. Here, is the pulse present? Yes. So I've got somebody who's got impaired mentation, but they have a pulse, they're pigeonholed as a red, urgent. If they can't follow commands, they don't have a radial pulse, you can see they fall into the expectant / deceased category. Now, the whole idea of making it very easy is that there's nothing to remember under high stress. Now, there is, in theory, you could have a patient that can't follow your commands but is screaming in agony and pain. You go to check a pulse and they don't have a pulse. So obviously, they are alive, but they don't follow simple commands, they don't have a pulse. By the guideline, by the tool, we would pigeonhole them in the expectant / deceased category. And the fact is that the research is showing that if they have impaired mentation and they're in a hypotensive state, their odds of survivability from the event are incredibly low. But again, I like to think about this as it's a tool for the holy hell moment. You've got 30, 40 patients. I need something that's easy. I need something that's easy as a process so there's less opportunity for the provider to fail in their efforts to triage adequately. This doesn't mean that when we get done, if the patient's still showing signs of life, they get treated. It's all the other triage models are the same. If I have somebody that's expectant, but miraculously they have held on through the event, then they get treatment. Or as more resources are available and I get the other patients evacuated from the scene, then I start taking care of that patient. The life-saving interventions we already talked about, controlling massive hemorrhage. Typically, tourniquets are going to be your first line of attack, but pressure bandages, wound packing, if we control the hemorrhage, the patient's survivability goes up dramatically. In this category, I would also abdicate the use of the pelvic splint because it's going to compress that pelvic cavity, minimizing blood loss into that cavity. If we open the airway for spontaneous breaths, that's immediately life-saving, and of course the needle chest decompression. This is taken right out of the guidelines, and as you can see, the first model that's in the guidelines for use for a triage guideline is the ramp triage model. And again, it's very simple and easy to use. Now within the guideline, as you look below it, we've got the SALT model that's included, and on the second page of the MCI triage guideline is also the jump start and start triage model. These were left in the guidelines for the big reason of any one of you could be mutual aided outside of your respective jurisdiction to an area that has not adopted ramp triage yet. For providers to do a quick review on the way to this incident, or to know how to do triage within their system or how it was done within their system, these are left in for a reference. And also left in for a reference because as jurisdictions adopt this and take it to be their primary guideline for sorting patients in an MCI event, it's going to take some time. RAMP is the model of triage that both East and West Metro are going to, and it's just obviously taking time for each agency to adopt the new guideline. As far as which one is best, in a side-by-side of all three, I looked at one study where SALT, START, and RAMP basically categorized all the patients the same. The only exception to that would be that obviously RAMP doesn't get any yellow patients, and if there were patients that were going to be categorized as a yellow, that doesn't exist within the RAMP model. But in essence, all patients were categorized the same. Statistically, there was no deviation. If you're wondering why RAMP came about, this came from the tactical medicine world and a lot of the efforts from lifesavers in Israel. And the whole idea is that they're looking at it as being a violent event that occurred, a violent man-made event, but it can still be used in any setting. But the whole idea was we had the bad event happen here, the X. And that's something that's referred to in tactical medicine a lot, is get the patient off of the X. This is the highest hazard zone. This is the area of insult. Whether it was man-made or natural disaster, the fact of the matter is, this is still a high hazard area. So the quicker we can sort the patients and evacuate them from the area of insult to a treatment sector and evacuate them from our treatment sector to a respective definitive care receiving facility, the better it is for the patients. It gets them out of the hazard zone, and the better it is for us, the rescuers. It gets us and keeps us out of the danger zone. There can be, especially if it was a man-made act of violence, there can be other attackers, there can be secondary devices, tertiary devices. So we really have to think beyond our normal scope. And even if it wasn't that act of violence, the tool still translates across multiple events. I'm a fan of it because, as I said, I study processes and I like simple processes. The simpler a process is, the less convoluted it is, the less I have to engage the cognitive and abstract thinking portions of my brain. Because we know as we get more and more stress and more adrenaline, those areas, those higher functioning thought processes are really dampened. So we need something that's easy for a rescuer. It's a very intuitive process. And it is. It's like, do I have to do a life-saving intervention? If I don't, because the patient follow my commands, do they have a pulse? It doesn't get much easier than that model. So with that being said, thank you for watching these two little video segments. When we come out to finish the flipped classroom model, there will be some scenarios involving head injuries. And so you might want to take a quick look at and refresh yourself on the head injury guidelines and perhaps RSA, RSI guidelines. And then for the MCI, we are going to have an exercise where you get to use the RAMP triage model in a scenario and get an idea of how it works and what works for you. With that being said, thank you for your attention. Be safe. We'll see you in the stations soon. Thank you.